Welcome, everyone. I'm so glad you're joining us this evening. My name is Jodie Gisser. I'm the Director of Development for Women's Health, and I will be your moderator for this evening. Before we begin, we have a few housekeeping items to review together. Participants are unable to share video or sound. Please note that if you have a question for the panelists, please click on the Q&A box. If you are on a laptop, the Q&A box is at the bottom of your screen. If you're on your mobile phone, the Q&A box is at the top of your screen. If you are joining us on audio only, you may email questions to events@med.unc.edu. We strongly encourage you to check the box to ask anonymously prior to pressing send. If you do not check this box, the panelists will be able to see your name and questions. When submitting questions, please do not include any personal health information that would identify you. By submitting a non-anonymous question, you are consenting that others may view your question. This webinar is being recorded. This webinar is for general educational purposes and does not constitute nor claim to be medical advice. Transmission of information is not intended to create a clinician-client relationship. Yes, now I would like to introduce you to a colleague of mine, Martin Baucom, who is the VP of UNC Health Foundation, to provide us with a brief overview on how UNC Health is responding to COVID-19. Martin?
Thank you so much, Jodie, and thanks to all of you for taking the time to join us today for this informational session on managing pelvic pain during the COVID-19 pandemic. This is, I know, a time of uncertainty for all of us, and so we hope that you'll find today's content helpful. So I wanted to provide, as Jodie said, a brief update on UNC Health's response to COVID-19. The good news so far is that physical distancing has been effective in North Carolina, and the preparedness and planning of our healthcare system and the commitment of our frontline care providers has meant that our system and our hospitals have been very ably served North Carolinians, excuse me. Now that we have met, we believe, this primary first wave challenge associated with COVID, we have begun a transformational recovery planning process, and we'll soon begin to see more non-COVID patients in our clinics. Our leadership and staff have worked really diligently to make sure that the hospital is a very safe place for patients at this time. The most current data show a curve that is less steep or flattening, which is not to say that the number of new cases is going down yet, but they're growing at a slower rate. The flattened curve also means that it's going to be a longer in duration curve. So when you turn down the intensity of growth, that increases the duration. And so now UNC Health is projecting that peak for treating patients with COVID across the system may come later in the summer. Currently, our statewide hospital data reflects that flatter trajectory, and we have fewer than 100 inpatients being treated across the system and about 30 in Chapel Hill. There are a few hotspots across the state, so our numbers may go up as a result of that. Our testing volume also continues to increase in North Carolina, and that includes a very accurate and robust test that you may have read about that was developed at UNC by Melissa Miller in the Department of Pathology. Our goal is to get up to about 4,000 a week of those tests done by July. We also recently began antibody testing. In closing, I'd like to say that our state and society as a whole really benefits from the guidance provided by academic medical centers like UNC. Working alongside our great and compassionate care providers are world-leading experts in infectious disease and epidemiology. Microsoft did an assessment of institutions recently engaged in coronavirus research based on research publication citations, and UNC was the top-ranked UNC university on that list, which is really impressive. The research expertise and the collaboration that informs the care our patients receive really is often attributable to philanthropy, which helps to integrate that care and research. We have established recently a COVID response fund that more than $1.5 million has been donated into. And a few examples of the impact of that fund. That's established UNC Health employee assistant programs to provide meals, groceries, and stipends for emergency child care. Thanks to philanthropy, we've been able to provide support for more than 500 children of 300 employees, which is really impressive. And that's just one example. So thanks to all of you. I know many of you have been contributors to these funds and others, so we're delighted to be able to present this program to you tonight.
Thanks so much, Martin. I really appreciate you taking the time to provide us with that update. And thank you again for everybody who's joining us tonight and for your support. We had such a fabulous response to tonight's event, and I appreciate everybody submitting so many questions for our panelists. We will do our very best to respond to as many questions as possible. So I'm going to begin by introducing our presenters, and I'm super excited that we are hosting this webinar topic, especially because May is Pelvic Pain Awareness Month. For those of you who did attend the women's event back in March, which seems like forever ago, you already know how knowledgeable, passionate, and fabulous our presenters are. For everyone else, I know you will join me at the end of tonight, and you will agree that these are two of the most fabulous healthcare providers that we have. So we have Dr. Erin Carey, who is the Division Director for Minimally Invasive Gynecologic Surgery for the Department of OBGYN at UNC Chapel Hill, and Dr. Jennifer Harrington, who's Pelvic Health Physical Therapy Clinical Specialist at UNC Health. So I thought we would start just as a way to get to know you a little bit better. If both of you could just share, how have you been doing? Personally, professionally, how have you been dealing with these challenging times? And are you currently seeing patients? What does that look like? What safety measures have been put into place to ensure that everybody is as safe as possible?
Yeah, well, first of all, I thank you so much for inviting us to present today. I'm really, really excited. But welcome to my office. This is my children's playroom. It's one of the few rooms that has a lock on a door, which is needed. But we are seeing patients, and this is really my home base right now. The majority of our visits have transitioned to virtual health, which I didn't imagine that in gynecology, but it works really well for a lot of our pain patients, even our surgical consults. Patients have been so incredible and really kind, and I think some ways it's bringing out some of the best in all of us, like this forgiveness and kind of we're in it together, and then being able to jump into clinical visits and really make gains. And we're still seeing patients both, virtually and in clinic whenever it makes sense, but it's been really bizarre. The only other thing I'll say is, and I know Jen has 2 young children as well, but if you hear screaming, everyone is okay. My husband has it under control. There's no way to really mute background, but that's kind of what we live in right now.
Similar for you, Jen? Yeah,
so I feel like I'm living like dual lives right now, like more than dual lives. So I, as Erin mentioned, have 2 young kids, so a 5-year-old and a 1.5-year-old. And my normal clinical schedule is I work 4 10-hour days during the week. So during COVID times, I have transitioned to kind of a PPE extraordinaire. So I got redistributed to a couple of different places. I've been collecting donations from the community. So amazing community members, maybe some of you made donations of different gowns and gloves and masks that have been so needed. So we were collecting donations from the community, and then I got redistributed and filtered into a different area at our central supply chain. So now I'm helping to disperse all of the PPE, emergency PPE orders to the rest of the healthcare system. So when one of our, when Rockingham needs some specific N95 masks, I'm the one who's like going and pulling the boxes and making sure that we have them and that we have the correct ones, and very much not physical therapy, but it's been kind of a fun change of pace. Just, getting a different glimpse into different parts of the healthcare system, which has been interesting. And I've met some really amazing people And I've been able to do some little side PT consults for them, which has felt nice to give back to them. And then just a few weeks ago, we started transitioning into doing some telehealth as well. So I've been doing primarily video visits for PT at this point, which, as Erin was mentioning, not what I necessarily envisioned for pelvic health. And I think both myself and my patients have kind of been like, how is this going to work? Like, so much of what we do is like manual, hands-on, like, you know, we're not having you disrobe from down below and like scooch up to the camera, you know, it's very different, not happening. But, you know, it's been surprisingly helpful, I think, from my point of view, and also my patients have given me great feedback. So I'm doing primarily video visits at the moment, but we are starting to see some patients in person again. Everybody is getting masks. So I have my lovely mask right here. So I'm in the clinic right now. So I work today. You know, we have a mask, patients have a mask. We've always been good at cleaning equipment and cleaning things, but it is like, you know, jacked up to a different degree that, you know, you never thought would happen. So yeah, it's, you know, it's been an interesting transition getting back into the clinic and sort of doing my normal job again, since I haven't been doing that for a little while, but, yeah, you know, we're all just doing the best we can in this weird time. But I'm happy to be here. Thanks for having me.
So grateful to have both of you. I mean, for you both to take the time in all of the chaos. I think what is the most special is that you're making the time for your patients in every way possible. And so we're just super grateful for that. So thank you. How about we start with just an opening question. What causes pelvic pain? And can it ever go away completely? Dr. Carey, do you want to start us off?
That's a huge question. And I think that, you know, one of my favorite slides to show when I'm giving a presentation, but if you can just imagine, if you just take every single system, right? Like the genitourinary system. So that'd be your bladder, the ureters, your kidneys, the GI system, right? Your colon, your rectum, like the muscles of the body, the reproductive organs, so the uterus, cervix, tubes, and ovaries. If you take all of those and you kind of can imagine anything basically below the belly button can really contribute to a pelvic pain presentation. And one of the complicating things is that when someone has a pain from either endometriosis or the bowel or the bladder, it's a really fascinating process, because it goes to the same little information center in the spinal cord that the many other organs go to. It's a little center called the dorsal root ganglion. And the pelvic floor muscles also go to the same information center. And there's this little cross communication that happens at that space called the crosstalk of the pelvic organs. And it's really pretty well established in like the pelvic pain community. And what that means is when one pain signal from one of those places goes to that information center, it talks to the other nerves and can actually send pain signals out to the other organs that didn't have pain to begin with. Like, mind blown, right? I mean, that shouldn't happen. And we see that in our patients. So women will have, I'm going to give an example of pain with just their periods, but over time, that pain may occur outside of their periods, but it feels like the same pain. And then they start having irritation of the bladder, and then they start having frequent bowel movements that are kind of painful. And then they have pain with sex. And it's like this process that can kind of grow. And so, I mean, I know that's a really big answer, but it's a really big question. And that's why the way we usually treat these is really in partnership. So there's very few patients of mine who don't go see someone like Jen, because it just doesn't work that way. It's like impossible for those two things to separate.
And can it go away?
You know, it can. When it depends, pain is also funny, because if you have it for a really, really long time, it may not go away, because over time there are things that happen in the nervous system that establish these really solid, you know, pathways. But what we can do is it can certainly be better. You know, I have patients who come in and they have 20 years of pain, and then their goal setting is, I want complete resolution of pain and no medications. And so that may be really tough, right? But if we kind of take a step back and say, well, what are your goals? Like, what are the things you really want to do? Oh, you want to sit on the bleachers when your grandson has a basketball game. Let's focus on let's focus on some smaller goals, and what you might find over time is that you're really a lot closer to those bigger goals of resolution of pain.
That makes sense. A question came in about medication, actually. So are there specific medications that are more helpful than others? Is that necessarily something that you go to right away, or do you look at mitigating issues differently?
You know, that's a good question. And I think that one of the first things we do is send people to physical therapy, right? If their exam is like, the pelvic floor is not great, like the first things we probably want to do is send someone to PT. And I would like to know, Jen, what you, like whenever we're sending someone to PT, like one of the things that's really nice about the UNC system is when we send someone to this team, if you're not improving, right? If we say, let's try without a medicine, they usually don't just keep you and let you not get better, right? I mean, what they do is they send us back to a message to us saying, gosh, you know, so-and-so is not improving, and maybe it really makes sense to add something to make this work better. And what do you normally do, Jen, when you see patients who may not be on a medicine who you think might benefit?
Yeah, so, you know, as a physical therapist, we can't give any specific medical advice, but we do have lots of experience with different patients with different diagnoses. So a lot of times, you know, we're trying to figure out, and we've read your notes, obviously, or wherever else they've come from, but we're trying to figure out what they've done already, if they've done anything at all. If they haven't done anything, like what does it seem like their symptoms may be coming from? Like, does it seem like it's more, you know, central nervous system, nervy related? Does it seem like it's more an issue in the tissue? Does it feel like it's more muscle spasm related versus, you know, the nerve issue? So we try to get that as best we can from our, you know, differential PT diagnosis stuff within our eval. And then we usually message you guys and, you know, ask opinions on, like, you know, what do you think about adding this? Does that seem like it would be something that's helpful? Or is there something newer that's out there that we don't know about yet?
Right. And we really, I mean, sometimes it makes a lot of sense to have medications on board. And certainly, depending on the patient and what you've tried before and what's been beneficial and what hasn't, like we take all those factors into play, because some of the medicines can be a little hard to take. And what we certainly don't want to do is decrease quality of life with side effects just to get your pain better. Because if you can't stay awake to actually do the activities you want to do, it doesn't make any sense, right? So there's a constant reevaluation of that. And the only other thing I would say is that you know, I think it's important to treat both the disease itself, so endometriosis, bladder pain syndrome, right? Treat the disease, but then you also have to treat the disease of pain. And that may include something like a centrally acting medicine, like an antidepressant or something, to downregulate that central nervous system, because you're treating the peripheral nervous system, because you're treating that disease. But if you're so ramped up that everything hurts, then we can't really focus on that small, like that more directed treatment.
Mm-hmm. Mm-hmm.
Yeah, I think one thing I wanted to add in was, you know, we've been talking about central sensitization a bit, where that whole central nervous system is just kind of ramped up and feels everything to the nth degree. And the thing that I think gets really tricky, you know, for a lot of people who we end up seeing in the clinic for physical therapy, is that at some point, it's not necessarily a tissue issue anymore. And the pain that's being experienced and the tissue damage or tissue injury that has taken place, or the disease that's in the tissue, sometimes they become not proportional. So pain in its purest form is there to let us know that, like, something terribly awful is happening and we should stop doing what we're doing. But with persistent pain, the output that you're getting from the brain isn't proportional to what's actually happening at the tissue level. So I think a lot of times with people who are seeing, you know, the impression is, I'm having so much pain, there must be so much disease, or I'm having so much pain when I do this, like there must be something terribly wrong that they're missing. And, you know, what I just kind of like telling people from a PT perspective is, like, you've been seeing, you know, some of the best people in the world for this thing, and they've been diagnosing and treating. And if there was like a big, bad, scary thing in the room, we likely would have found it by now. And it truly can be, the system is sensitized. So sometimes even just mentally knowing, like, it's not, you know, the pain that I'm feeling right now is not proportional to damage that's happening. Even just knowing that can help the system quiet down,
Right.
so that it doesn't keep giving you alarm bells, you know, when the wind blows.
Mm-hmm. For those who aren't familiar with what pelvic PT is, can you just talk a little bit about that? What does that look like?
Yes. So I'm a physical therapist, just like any other physical therapist that's out there. So most of us are trained as generalists. We graduate from PT school. Typically these days it's with a clinical doctorate, so a DPT, which is usually a 2.5 to 3 year program. Some of us have gone on to do residencies and specialty trainings as well, but not everybody. And there's lots of extra continuing education course. So in PT school, they don't teach us much about the pelvic floor, so that's extra training that we do on the side. So if you've ever had physical therapy for anything else in your body before, whether it's the back, the shoulder, the hip, the knee, we do very similar things within pelvic floor physical therapy. So we're musculoskeletal experts. We take a look at the body, we watch how you move, we check out the tissues. We do lots of education about bowel, bladder, sexual health. So a lot of what we do within pelvic PT is really lots of education about like what is normal. Because I don't know about all of you guys, but until I started doing this as a specialty, like I didn't know how many times a day like you should be peeing or pooping. I didn't know, you know, what technically defined. I thought I knew what constipation was, but like it turns out like maybe I didn't. So there's lots of different things that I think just the general public isn't told. Like I think we all should come with like a pamphlet when we're born that's just like, here's the norms so that you can start to figure out when things deviate from the normal. Because some of us have had stuff going on our whole lives and we just don't even know it. Mm-hmm. So pelvic floor physical therapy, it's physical therapy like any other therapy. It just adds in the component of potentially evaluating and treating the pelvic floor muscles. And what that means is, so there's lots of different ways to assess the pelvic floor. The pelvic floor can be assessed externally through clothing. That's kind of like the least invasive, also least reliable way to assess the pelvic floor, but there are options for that. Kind of next up option from there would be kind of external pelvic floor assessment without clothing on, but not doing any kind of internal palpation or checking. And then I would say most commonly what we're doing when we're doing our assessments, assuming that everybody is okay with it, is doing an internal, often vaginal pelvic floor muscle assessment. There's potential sometimes for an internal rectal assessment, but typically when we're working with somebody who has a vagina, it tends to be the more tolerated, more familiar hole to be penetrated. So we often will do an internal vaginal pelvic floor muscle assessment, again, with consent. And when we're doing that, we're checking for things just like we are with the rest of the body. So we're checking for muscle strength, muscle coordination. You know, does your brain know how to talk to those pelvic floor muscles well? You know, I think, you know, they've done some studies that show that people trying to do a Kegel or a pelvic floor muscle contraction, like 50% of those people aren't really doing it the right way. And if you're not doing it the right way, it either can make things worse or it's completely ineffective. And I think there is a little bit of a misconception that pelvic floor physical therapy is synonymous with pelvic floor strengthening and Kegels. And for us, especially with our pelvic pain population, it's often kind of the opposite. Like instead of doing up training and strengthening, we're often doing kind of down training and relaxation because muscles need to be able to relax just as well as they squeeze. Mm-hmm. And I would say if I had to make like a blanket statement rule, which everybody's always individual, but I would say with pelvic pain, more times than not, the muscles are too tense, not just plain old weak. They may be weak and tense, but it's often not just like they need to be stronger issue.
Mm-hmm. And are there specific, I think so. If not, we'll get more questions and then I'll circle back.
Perfect.
Are there any exercises that you can suggest that people could do at home?
Yeah, so there are lots of different things, and it's so hard because truly, in some ways, I give a lot of people similar exercises to start off with because there's some very basic things that you can do that can be helpful. So I'll teach you those in a second. And in other ways, you know, it's very individualized. So if I had to like boil it down to like one simple statement, it's just do something different. So if your body is really good at being tense, teach it how to relax, which is sometimes easier said than done. You know, if your muscles are really weak, then they need to be strengthened. So it truly is finding like, what is your current pattern? What is your current state? And then trying to do the opposite or at least a different option. So 2 of the pelvic floor relaxation exercises that we do with patients are called, so like core breathing or 360-degree breathing. And then we also can do some windshield wipers. So I will attempt to demo these for you right now. I don't know how well you will see it over camera, but I'm going to lower my screen so you're going to get kind of like a chest and belly shot here. So with core breathing, I'm going to put my hands kind of around my lower rib cage. And when I take a nice deep breath in, I want my ribs to expand in all directions. So not just belly breathing, not just side breathing, not just back breathing, but I kind of want my entire rib cage to inflate, almost like I was putting air into a balloon. So as I do a deep breath in, I want to expand. And then as I exhale, things will come back together. So inhale, expand. And then exhale. So along with that deep inhale, in theory, what should be happening is the pelvic floor should also be relaxing and just kind of letting go with that nice deep inhale. The problem is sometimes people can't kind of get the breath. And it's not that the breath is actually going into your pelvic floor, it's staying in your lungs, but sometimes we're just not getting that like coordinated respiratory and pelvic diaphragm piston. So one of the first things we do with people is deep breathing. So if you guys right now, if you're in a position where you're sitting, if you just want to sit on your hand, so literally just like take your hand and like sit on top of it, lower down here. So just sitting right on top of your hand. So if you take a nice deep breath in, you can try to think about your breath kind of reaching down to your fingertips. So your fingertips should be kind of right on the inside of your sit bone. So that's exercise number 1 is core breathing. Exercise number 2 is a simple one. I'm gonna get on the treatment table for this. So we call them windshield wipers or just hip rotations, and you lie down on your back with your legs out straight. And then from the hip joints, you roll your legs in so your toes point in, and you roll your legs out so your toes point out. So you roll in, you roll out. So from this angle, it would be feet out, feet in. And all that's doing, so the obturator internus is one of our hip rotator muscles, but it's part of the pelvic floor. And for a lot of our patients, that obturator internus muscle is overly active and overly tense. So just doing that little simple hip rotational exercise is like a retraining to help teach that muscle. There's an on position, there's an off position. So it's just not so grippy and on all the time. So I would say those are 2 of like the simplest ones.
And how many, like how long do you do that?
Yeah.
So how many deep breaths or how many, you know?
Yeah. So often for the deep breathing, I'll recommend doing somewhere like 2 to 5 minutes a couple times a day or 3 times a day. For some people, they say, I just can't do that. Either it's too boring or I get too lightheaded. So truly just doing even like maybe 4 deep breaths and just taking your time with it, really allowing that to go. But somewhere in the 2 to 5 minute range, if that's tolerable. And with the hip rotations, you know, picking a number like 15 or 30. So in and out would be 1 repetition and doing somewhere 15 to 30 of those. And you can do those lying down in bed. So both of those can be done before you get out of bed in the morning and before you go to bed at night. It doesn't have to be like a big production. There's many other things, but I'll stick with those.
Thank you for sharing that. Thank you. Dr. Carey, are there any specific things to avoid which are known to trigger flares or burning symptoms?
Well, flares is kind of the most common term which used when someone who has chronic pain has a peak in their pain. I'm using my hands a lot because usually I have like a slide that shows like a peak. And that's actually kind of, I mean, part of the disease process. So getting a pain flare happens for a variety of reasons. And the triggers are different for a lot of people. So what I say is find out what those are, and there are ways for you to track those yourselves. There'll be some resources at the end of the slides, but there are some apps that you can use if you don't know what your flares are. If you say, I haven't really been paying attention, you know, I've been too stressed out, or that might be a flare, right? I mean, stress, flares, chronic pain. I've had a lot of my patients who've had more pain, especially during the current crisis, right? They're not as active as they used to be, which may actually be really helpful for their pain. They're not distracted. They don't have the relationships that they normally have. And then they have a stress of the, pandemic, right? So it may be more flared up just because of the stress of the current environment. But what I would say is if you don't know your triggers and flares, write them down in a journal. If you say, I've had a really bad day, when I rode in the car for 2 hours, right? Or I did like that must have been, and then follow that. And there's an app that you can use to track your flares. And there's a couple of them. One of them is called Pain Companion, where you can kind of log your pain and your symptoms. There is a app called Flare Down, which is really popular with some of my patients, that helps you, and that's a free app on both Android and iPhones. I don't have any financial interest in any of these, but that can be really helpful for tracking a lot of different things like food, your mental health, what your overall activity is, what your stress level is. And so I would say first thing would be identify your flares. And if you know your flares, do your best to mitigate them. We are all super stressed right now. So we can't just like shut that part off, right? Like we cannot pretend that we're not in this environment. So, but what you can do is give yourself a little bit of grace and be really kind to yourself and just say, okay, I'm having a flare. Here's my plan, and this is how I manage it. I think for a lot of my patients, you may have, and some of them might be on the call, but you may have a pain flare plan. And that is, what do you do when your trigger occurs? And there was no way around it. You walked those extra 30 minutes because you were enjoying the sun, and then you are having more pain. And so you have like kind of your own toolkit, so that you've identified certain things that maybe you don't want to take all the time, right? Like ibuprofen or Tylenol or gabapentin, or that muscle relaxant that makes you really tired. Some deep breathing exercises, some meditation, like a kit that is they're your resources to manage that flare. And there's been, some pretty good studies that have shown that when a patient feels like they have control over their pain, and they understand that, okay, it may not completely go away, but I know these 3 things work. I'm going to have a hot bath. I'm going to listen to Headspace. I'm going to read my book, right? Those 3 things are what works for you. Your pain is less. And so I think, know your flares, have a toolbox, a toolkit. And if you don't, talk to your doctor about getting one, and put things, both medicine and non-medicine things in there, right? You might use the windshield wipers. You might use, your Headspace app. You might call your sister. Like, there are things that you have that work for you, and build that so that when you have a flare, not if, like you will, how are you going to handle that? And then you aren't as scared and nervous about it.
One of the other things I love to tell people, and this goes for any persistent situation. So if it's persistent pelvic pain symptoms, if it's persistent like other pelvic type symptoms, or really any pain anywhere in the body, anytime we have a persistent undesirable thing going on, it's like we're constantly depleting from our bank all day long. And by the end of the day, we are just like tanked and just done. And especially, that's in non-COVID times, right? So now throw COVID on top of it. Maybe right now you're also a teacher. Maybe you're also nannying because you have family that's little that needs to do things. We're all doing things now that are outside of the scope of what we typically do, which is stressful in and of itself, even if it's not a bad thing. So often we're doing things kind of like just to stay afloat and just to get by. And it's a very like NCAA survive and advance mentality, which is not necessarily, rejuvenating, and helps us kind of live our best versions of our lives. So one of the things I love to tell people is, if you can find the time and energy to create a list of things that bring joy, and that could be anything. So like things that incorporate all the different senses. So like a certain smell that you love, maybe it's a candle, maybe it's an oil, maybe it's a lotion, if there's a song that anytime you hear it, it just like, it perks you up. If there's a picture, if there's a texture that feels like really soothing and comforting and soft, literally anything. Maybe it's writing, maybe it's reading. It could be anything that brings joy to you. And my list would look different than yours probably. And if you can try to pick 3 things to do from that list every single day, even if you are having like the worst day with the most pain and everything has just been crazy, if you have the list already set and somewhere that's accessible, and maybe you do have that, lotion right next to your bedside table, like you can take the extra second to just open it up and take a sniff, or like put some on your hand. So if we can do those little things to put back into the bank, it often contributes to us feeling less depleted at the end. So I think, especially right now, I think that that's like something that we all can do, and I need to be better at it myself. I should practice what I preach, but I feel like that could be helpful.
I love that. Thank you. I do think we could all benefit from those reminders of self-care, self-preservation, self-care.
And I'm just going to add to that, because there is a Grateful app, And it is, I'm all about the apps right now, but I really am, because it's a way that we're staying connected, right? And the way we're doing things right now. And I believe it's a free app, and it's a gratitude journal. So it's a way to, you know, the things that bring you joy, the things that you're thankful for, this really works. And it certainly is one of the, you know, if you look at some of the happiness literature, being genuinely grateful for the good and the things that you find bring you joy, and maybe how you contribute to something that you feel is meaningful, right? And I've had friends who've really felt good about participating, even though they're not healthcare workers, but they've contributed to like the PPE fund at their church, or, you know, there's ways around that actually is really healthy and healing for us as human beings. So I'll stop with the apps.
It is very powerful, though. I mean, that's a lot of the reason why I think we've been getting so many contributions for the COVID fund, is because people don't know what else to do, and this is one way that they can do something positive. Yeah, it is very powerful. Thank you for that. One question is pretty specific. The question is, should I be concerned about cancer if I have uterine fibroids and polypoids with some discomfort?
So uterine fibroids and probably polyps, or maybe poly.
I don't know, it's OIDS.
Okay, I would think
polyps,
like uterine, like polyps, probably. So a couple of things come to mind. I mean, first of all, uterine fibroids are incredibly common, and if you know, the majority of women who have fibroids keep their uterus and they don't have to have any treatment for it, right? But as we age, if we have fibroids or uterine polyps, they may need to be monitored or managed depending on the symptoms. So we definitely get worried if you're older, so postmenopausal, after menopause, if these are growing, or if you start having bleeding that may be associated with polyps, then you might have to have some kind of evaluation, like a biopsy of the lining of the uterus, maybe an ultrasound of the pelvis, just to evaluate these. We typically, you know, uterine polyps, if they are symptomatic, we recommend removal of those. And that's a really simple, straightforward outpatient procedure where you can put a camera through the cervix, and you can look inside the uterus, and it sounds bizarre, you fill it up with water, and you can look inside with a camera. And then if there's anything that's concerning, like a polyp, and possibly a fibroid on the inside, then that might be biopsied or removed. So I would say, you know, age and symptoms would dictate that. It would be incredibly rare for a fibroid to have a cancer, and we don't usually do routine monitoring of those.
Okay, thank you. Related to that, having uterine fibroids, could it be the reason why I have some minor cramping in my pelvic and lower belly area at night?
It could be. I think that I don't know why it might necessarily be at night. Maybe it's just the first time. I think that sometimes pain is worse at night for a lot of people, and it's probably first time people remember or recognize they have pain, right? They may have pain all day, but they're busy, and then you finally lay down and you're like, oh my gosh, that is really bad. Certainly fibroids can cause cramping, and if they're large, they can outgrow their blood supply and actually cause quite a bit of pain and discomfort. And then if they're just bulky, like, I mean, a normal uterus is smaller than my fist, right? So if you have something that is the size of a grapefruit in your pelvis, that might be really uncomfortable. I mean, there's not a ton of space there, and it lives next to the bladder and the bowel. Oh, that is not a lot of space in there. So it kind of shows that, yeah, look at that. That's what the size of a normal, you can show those pelvic organs there.
Exactly.
All right, so this is so if we were looking just directly at you, that your uterus would, in most patients, would sit right on top of your bladder. So if you had a grapefruit on there, it might cause pressure, feeling like you have to pee. Yep, there you go. It's beautiful. Oh, and there's that sagittal view. I didn't know this was going to be such a
here all night.
So what I would say is, if you do have pelvic cramping, and you have a good sized fibroid, it certainly could be the cause. And Uterine pain often responds to like a NSAID, like ibuprofen. We certainly don't want you taking that every night. So if you find you're having pain that is requiring daily use, like you should come see, us, and we can definitely talk about that more.
Okay. Can you talk a little bit about incontinence, which makes me grip more, and that's what causes discomfort?
Jen.
Yeah. So there's a lot to say there. So there's actual urinary incontinence, which we define as, the involuntary leakage of urine, and that could be a drop, or that could be a full loss, or just a larger leak. It could be any of those things, but it's any time that urine is leaking when it's not intended to be passing from the body. So that's what urinary incontinence is. So sometimes there is actual leaking that happens, and that could be something like stress urinary incontinence that happens with coughing, laughing, sneezing, jumping, running. So anytime there's an increase in intra-abdominal pressure from a force, there's leaking that kind of expels urine from the bladder. So that's stress incontinence. Then there's urinary urge incontinence, which is where there's an urge to go, and then there's a leak that happens either immediately or maybe even right as you're at the toilet taking your clothes off, but you just haven't fully intended to go yet. So that would be urinary incontinence, both stress and urge. Then there's this like in between area where maybe you have issues with leaking, so then you almost become hyper attentive to the leaking, and there are feelings of an impending leak that might or might not actually happen. So it's very rare that one would just have like leaking all the time, like a full-on stream all day, every day, unless there was something really anatomically, like a male after a prostatectomy who has not had a nerve sparing procedure. Like that can be more of like a constant leak that may feel like it's happening. But especially in female anatomy or cisgender female anatomy, I think it's certainly less likely. But there can be the sensation of, I know I leak, I've leaked before, now my muscles are kind of gripping to kind of try to prevent that leak. And sometimes when we feel like there might be a leak, it might actually not always be a reliable feeling. Feelings are really unreliable, which is really hard because you're feeling the thing and you want to attend to that thing that you're feeling. So I would say the first step is acknowledging. So acknowledging that you're holding on to that extra tension is the first step, because when any muscle in your body is holding on to too much tension, it just can't function fully like it needs to. So if my bicep muscle, so this muscle right here, was constantly contracted like this, I may only be able to do this, but I need my bicep to be able to lengthen fully and then contract in order to maybe pick something up from the ground. So if your pelvic floor, which is supposed to kind of close off the holes down below and also lift things up from down below, if it's already held in kind of a short, tight position because you're trying to prevent a leak, if you're already holding on to that tension, then when you go to do the thing that might cause the leak, whether it's an urge or whether it's that cough or sneeze or jump, your muscles have nowhere else to go, especially if there's underlying muscle weakness as well. So gripping and holding the tension is often counterproductive because it holds the muscles at this like shorter, lengthened position where they can't fully squeeze and can't fully relax, so they can contribute to actually more leakage and potentially more pain. So it feels like it should be helpful that they're more tense for the leaking, but it actually can make it worse with the leaking. So actually learning how to let go is really the thing that we teach most of our people right away. And it's hard because we just, like a dog when it's scared pulls its tail between its legs, human beings do the same thing. And whether it's stress that's triggering us or the fear of leakage that's triggering us, or maybe a past traumatic event, muscles have memory for better or worse. And sometimes their memory is that they live in this short, tight position. So just acknowledging that tension and trying to let it go, but not forcing it, is often kind of the first step.
That's super interesting. I like the dog analogy too, because you can visualize that. Yeah. What is the most current advice to address high-tone pelvic and rectal spasms?
Yeah, so advice, evidence, there's like differences of things there. So within pelvic floor physical therapy, I will be one of the first people to admit that there's not necessarily a lot of like good, beefy medical literature to support some of the things that are done, but I can speak definitely to my own personal experience and advice and how that's kind of changed over the years. And maybe some of you have seen me before, so maybe you'll think I'm full of it right now. But we change, we grow, we learn different things. So I think a really old model for treating pelvic pain is doing a lot of internal pelvic floor soft tissue work to release muscles that are tight. And there's this like need to see a skilled therapist who can do that thing to make everything better. And I think that that is still a piece to the puzzle, but I think it's less of a piece than it used to be. And movement and doing things differently, I think, is where things are starting to go a little bit more. So the manual piece can be really, really helpful. And we do definitely still do internal manual pelvic floor therapy when that's needed. We may teach patients how to do self-release techniques if that feels like it's something that's helpful and needed. We love to have people have their own skills and tools to help themselves feel better so that they're not feeling dependent upon us to help. But, you know, I think things are trending a little bit more towards like encouraging movement, encouraging activity, because we know that this pain that's being experienced isn't necessarily related to the tissue anymore. Like, it's not uncommon that I'll see a patient and they will have some extra pelvic floor tightness that I find at evaluation. And over time, I'm like, oh my gosh, your pelvic floor feels so much better. And they may say like, but I don't feel better. So at that point, you know, there's been a true improvement to the muscles, but there hasn't been a true improvement to the pain experience. And some of that is, again, just the nervous system. So I think, you know, best advice at this point is kind of do all the things and do things in different ways. And it sounds so simple to just do something differently, but if your body only has one motion and one way of doing things, so if you only ever squat in a certain way because you're trying to maintain good form, and you do that over and over and over and over and over again, and that's your only strategy, we often develop overuse type injuries or pains or irritations. So, you know, I think in the clinic, we're doing a lot more of like trying to find different movements and different strategies for moving and doing things, because if the pain's going to be there, whether you have tight muscles or no tight muscles, we really need to teach your body how to move and do things in the presence of the pain, with the intention of trying to get the pain down there and get the pain to go away when we can. But I think, you know, movement, you know, motion is lotion. I forget who said that, but it's a thing. It just helps the system. It helps the nervous system. It helps mood. It helps everything else. So I think best advice is, you know, flying under the pain radar, not plowing through pain. So it's not a no pain, no gain approach. Mm-hmm. But I think some manual work can be helpful, but I don't think that should be done forever. And that shouldn't be the one thing that makes things better always. I think there also should be movement and exercise and a lot of self-efficacy with like tools and things that you can be doing independently to help yourself feel better.
And I would just add, sometimes, you know, sometimes these spasms can't be stopped without a medicine, right? Yes. So you do all the things, and you're in the bath, you're stretching, you're doing the deep breathing, and that's not like kind of abortive therapy for the spasm. Sometimes it does make sense to use, depending on the cause of the pain, sometimes we add muscle relaxants, very specific ones. You know, if you have too many systemic side effects, like if you say I can't take a muscle relaxant, there's a few that we can compound and either have them made into suppositories for the vagina, baclofen suppositories, Valium suppositories. Sometimes just placing those tablets in the vagina has some effect. So, I mean, there's a way to use certain medicines to then help those therapies, you know, and that might be part of your toolkit. And I think in some patients who have persistent spasms, sometimes we do things like trigger point injections of the muscles to actually kind of stop that spasm. So just by whether you inject something in it or not, so you can use a dry needle, you can use a you know, something with lidocaine or a steroid, but what you're doing is you're putting a probe into the middle of a really tight knot or, you know, trigger, hence the word trigger points, and you're depolarizing that. And so it's actually being physically made to just let go. And it's really fascinating. So that can be helpful. And then, you know, in some patients, we also use things like Botox therapy, where we use, yes, the same things you inject into your face and sometimes your bladder, we put into the pelvic floor muscles at kind of lower doses. So it's not going to, you know, things aren't just going to fall out, right? But it's enough sometimes to make some of those gains with physical therapy. And Botox is really unusual in a couple of ways. One, it's unfortunately not covered by insurance. So it's this like kind of this gray area of, you know, insurance companies not paying for it because there's not an FDA indication. There's a lot of literature, not an FDA indication, right? So we use it in an evidence-based practice, but what it does is it not only stops that ability to completely form that muscle contraction of the levator ani muscles, which are the same muscles that go up around the vagina. They also go around the rectum. Get that
Passing it out.
Pelvis over here.
Bring it back.
All right. Yep. So that's like a hammock of the levator ani muscles, and they go, you can see around the vagina and then around the rectum. So it relaxes those, but it also has this really interesting effect to the nerve fibers in the that go through the muscle, in that it's very soothing to the C afferent nerve fibers, which carry the pain signal. So it doesn't work for everyone, but we do have a lot of patients who can have benefit from that piece of the pelvic floor. And if you just want to show us that again, and you can tell us about it. Oh, it's great.
There's the superficial pelvic floor.
Do you want to show them like where the urethra and vagina and rectum are?
So we've got the urethra, the vagina, and then the anus right back there. So if we come in
and just behind, you show the levator ani muscles too on the outside, so that they can see how it's like this.
So looking from the outside, so it's like the front to back hammock part.
I think it's just like the best picture to just kind of show it really is holding all of.
So this is my finger inserted vaginally and pressing off to the side here. So this is the whole levator ani group. And then this muscle over here is that obturator internus that I was mentioning, that hip rotator muscle. So kind of that whole parts of pelvic floor. So the bigger hole in the middle is the vagina. The hole at the top is the rectum in this view, and the urethra would be a smaller hole kind of below the vagina in this angle.
Awesome.
I didn't know we would have props. Thank you.
Neither. It's great.
Just in acknowledging the time, one more shout out. If anybody has any questions they would like to submit, please remember to submit them via the Q&A button below. And if we weren't able to respond to your question tonight, please feel free to contact me and I'll pass your questions along to our panelists. Before we conclude, I do want to make sure that we put that resource slide back on. There it is. Thank you. And again, this is being recorded, so I'm happy to share this with anybody on the call tonight. Before we conclude, any additional thoughts, Dr. Harrington, Dr. Carey?
You know, I think that, I just kind of want to give everyone a hug right now. I think that this is a really super hard time, and I think that piece, of kind of just knowing, like Jen said earlier, we're all doing our best. And I think that when you remember that, you're a lot more, I do better. So I think that we're all doing our best. And so I think with some of these things, working with your healthcare team, using your family and friends, like reaching out in whatever way we can, right? We don't have that ability to do all the things we could a couple months ago, but there are still ways. So technology works. Look what we're able to do tonight. FaceTime your mom or your friends, really make something that's regular that you can look forward to. I have a lot of patients who are going to church electronically, and they feel even sometimes more involved in their community because maybe they couldn't go as often because of mobility or ride issues. So I think that there's some ways that this is going to be really helpful. But use your resources, and then sometimes if you have a flare that's not working, then just kind of be accepting of that too, right? Try all the things, and then sometimes it doesn't work, and sometimes when you're in a place where you're like, today's not going to be the day that I'm going to go do all the things. Mm-hmm. And sometimes just acknowledging that and kind of that acceptance is really helpful.
Yeah. Yeah. We did get one question that just came in. What do I do for a PGAD flare?
What I would say is, PGAD is a persistent genital arousal disorder, and it's actually really, really uncomfortable. So it can feel like that arousal period before climax and before orgasm. And it can be incredibly disrupting and uncomfortable, and has a huge emotional component too, where you feel that maybe if you were able to climax, you would have that release, and then that sensation would go away, and it just doesn't go away with flares. And So usually, I mean, apart from like deep breathing, I think that ice application can be really helpful in kind of like taking some of that really intense sensation away. Be careful when you apply ice. So make sure you have it like wrapped in something, because if you put it on the clitoris and the vulva, sensitive tissue, so it's not super, you could easily burn yourself, right? It's not super tough. So ice application, if you have topical lidocaine therapy, you can use a small amount. You can get some of that over the counter as well, so that can kind of take some of that sensation away. Those are probably the two easiest things to do. Sometimes using more in intervention procedures, like if it's really bothering you, having like a nerve block if you have a provider that you see that can kind of calm that nerve down, especially in a really big flare, that can also be helpful. Are there some muscle like relaxation things that patients can do, Jen?
Yeah, so similar to what we talked about before, so doing that core breathing, doing those hip rotations, I think it really depends. So everybody who I've seen who has PGAD has a slightly different presentation, I feel like, and there are slightly different things that either seem like contribute to symptoms or like are very predictable. Like for some people, it's, anytime I do more physical activity, like it totally ramps up then. Other people, it's completely random. It just seems to happen all day, every day, or certain times, so I think it really depends on like what it is that's actually causing it, whether it's an anatomical difference, whether it's, muscles that are overly active. If it's a muscle piece that's overactive, learning to try to, down train and relax those muscles can be helpful. The other thing that I would say is that kind of like some of our patients who we see who have, they'll call it like dysenergic defecation. So they may be squeezing their muscles when they're trying to have a bowel movement instead of relaxing them. So they're doing the opposite. Sometimes trying to relax those muscles can just feel like you're fighting a losing battle, because even though those muscles are under your voluntary control, there's such a muddy brain pelvic floor connection for, I think, most people. Because your pelvic floor muscles are internal, they're inside the body. If you injure your hand, you know what your hand looks like. You have a mental map of where your hand is and how to move it. The pelvic floor, there's not often that like same solid connection. So I would say if you're trying to relax your pelvic floor muscles, and if you're feeling like you're not having any success, like try not to feel frustrated with it, because it is, there are ways to help get to the muscles a little bit better. There is like one other relaxation exercise I can show super quickly. It's called the pelvic floor muscle drop. And for some people, this is really helpful, but not for everybody. So I'll try to do it from a couple different angles. So from this angle, so you bring your knees up. Sorry, let me terrible angles. Need a person in here. So you bring your knees up, your feet together. So knees are out, feet are together, and you put your hands on the outsides of your knees, and you push your feet together while you simultaneously try to pull your knees up and out, and you resist. So it's an isometric, so you're not really moving anywhere. Let me go from the other angle so maybe you can see. So it's like this. So you push feet together, knees are up and out, and you're activating a whole bunch of other muscles with the intention of trying to shut off your pelvic floor. So it's like it's an indirect way to get the pelvic floor to calm down. So sometimes when you're not consciously able to tell the muscles to relax, sometimes doing one of those little like overflow techniques can be helpful. Mm-hmm. Or doing like a deep sumo squat if you can get into that position and that's not irritating. So that would be more like getting down here and just kind of hanging out. But for some people that may feel really uncomfortable for different reasons. You can do the same thing, kind of lying down on your back, pulling the knees up to the chest and resting them out like the happy baby pose.
Thank you. Thank you. You really went the extra mile there. I'm
a little winded.
I feel like I should do like a jumping jack or something. I don't know. I haven't moved.
You should see my video visits when I'm like literally I'm on the floor, I'm on the ground, I'm on the table, I'm up in the air. It's everywhere.
That's patient care. Okay, I want to remind everybody, before you exit, please you'll see a poll that comes up, so it would be really helpful. Oh, there it is. Please take that poll before you exit. If there's the link for the COVID response fund that Martin Baucom talked about earlier, if you would like to support that fund. I really want to thank everybody for coming tonight. Dr. Carey, Dr. Harrington, we greatly appreciate you sharing your wisdom, your expertise, and we are so grateful and fortunate to have such dedicated healthcare providers. Last reminder, the session was recorded, so again, if you would like me to provide you with that link, I'm happy to do that. Also, answer any questions that we didn't get to tonight, just reach out to me. Thank you again, and please take good care and be well. Good night, everybody.